Good afternoon, members, and welcome to this Health and Wellbeing Board meeting today. Can we start with agenda item 1, please, that's on today's agenda, which is election of chairman. Do we have any nominations, please?
I'd like to nominate Councillor Sue Woolley, please, if I may. She's done an excellent job for the last few years, and I'm sure she will do again if we can elect her today. So that's my nomination.
Thank you. Do we have a seconder for that, please? Are there any further nominations, please? Okay, so it's proposed and seconded that Councillor Woolley be the chairman of the Health and Wellbeing Board for 2022-23. Can we vote on that, please? Can I have all in favour? Can you please raise your hand? Those against? Any abstentions? I would like to take your seat.
First of all, colleagues, thank you very much indeed for your continued support. It is very much appreciated, and I like to think that we work as a team and that it is for the continued benefit of our residents, our patients and anyone else that happens to live in the Lincolnshire area. I would like to now move on to item 2, which is the election of the vice chairman. He's fighting to get in the car park at the moment, so I don't know if we can do it without him, but I would like to nominate John Turner as our vice chairman for the forthcoming year. Can I have a seconder? Thank you. Seconders all over the place. Thank you. Thank you. Say again? Well, he's not here, so we'll just have to move on, won't we? Can I just formally ask for your, is everyone in agreement, or at least is that acceptable? Thank you. Anyone against? And any abstentions? Okay, thank you. That'll teach him to be late, won't it? Okay. He's just parking, you see. Right, okay. Can we now have apologies for absence, Katrina?
Thank you, Chairman. Yes, we've received apologies for absence from Councillor Bradwell, Dr Jerry Massauli, Sunhill Hindosha, Sarah Connery, Sarah Fletcher, and Julie Debenham. And Julie Debenham is now the representative for Lincolnshire Police in place of Jason Harlan. And we've also got today a replacement member for Sarah Fletcher. We've got Pauline Mountain for this meeting only, and Pauline's over there. And can I also say, Chairman, that Philip Clark, the Deputy Police and Crime Commissioner, is now the representative for the Office of the Police and Crime Commissioner. But unfortunately, he's not here yet. Thank you.
Okay, thank you for that. John, you'll be delighted to know that in your absence, and this will teach you, you have been nominated, seconded and voted in as the vice chairman of this particular committee. That's all right, it's a pleasure. Can we now move on to the minutes of the previous? So, as is usually the case, I'd like to go through first of all for accuracy. So we will look at the page numbers as they are at the bottom of the agenda sheets. I think they might be different if you're online or if you're on an iPad. I don't think the pages necessarily show. So page 5, page 6, page 7, page 8, page 9, page 10, page 11, page 12, page 13, and page 14. As I don't hear any issues or objections at all, I will take those as read.
Do we have a proposer and second for those?
Can we?
Chairman?
Yeah. Do we have? Thank you, Councillor Bowkett. Thank you, Councillor Rawlins.
Are we all in favour?
And any? Can we all vote on those as being correct? Any? I'll just take anyone against, or any objections. Okay, thank you.
Thank you, Chairman.
Item 6 is the actions update, and I would suggest that the two on page 16 are our two that were raised at our last meeting. And I understand, Alison, that a briefing's been sent to all of the district councillors, as you've written here. Councillor Wright, are you comfortable that the district reps have had that information?
Thank you, Chairman. Yep.
And then again, the email providing the Health Watch arrangements, that again has gone out for the PNA.
Yes, it has, Councillor.
Thank you. Agenda item 7, you'll see is Chairman's announcements. I'm certainly not going to read through it. I assume that you've all read it all. Just want to add a couple of extras to this, which have happened in the last week. The inaugural meeting of the ICP chairs took place last week, and I think you can safely say there are not two systems in the country that are the same. There's a combination of ICB representatives, who are also ICP representatives. There's ICPs that are covering, chairmen that are covering both the Bs and the Ps. And I think it will tease itself out over time as to what works for each individual system. But I think it's really helpful, certainly from a local government perspective, that NHS Confed, together with the LGA and the providers, have been fairly flexible around that arrangement, around, let's let everything bed in and then look at it probably at a later date. Interestingly, you will know, and we will come on to this in a moment, that we had for a while used our Health and Wellbeing Board. We're one of 4 in the country where we're coterminous with the boundary of the ICS, with the upper tier local government, and it was no, we can't have our ICP being the same as the Health and Wellbeing Board. Now that has that's softened very much, and I think from our point of view it was seeming pretty obvious that what they would be one and the same. I accept it doesn't work for everywhere, so I think it's a case of watch this space. I don't think the detail is completely finalised yet, but that was the main bit that came out of that meeting. And then just this morning rather, NHS Confed had, or through Amanda Pritchard, had asked Claire Fuller, who is a GP in, I think it's West Sussex, to actually put together a paper around the future of primary care, and she has reported back to various levels, both of government and indeed within the NHS, and that meeting took place. She gave an hour of her time this morning, again for the ICP chairs and chairs-elect, and that was really interesting, again from the primary care side of things, that that exactly where we would probably think GPs are going, but of course primary care includes the dentistry side of things and all the extras that we are shortly to take responsibility for. So good place to be, but of course this is all coming through and will be in place for July the 1st, isn't it, John? Okay, so if we now move on to well, I was going to say page 19. These are the assurance updates. Again, I am assuming that you have read them all. Does anyone want to pick up on any points at all around these assurance reports? Is everyone comfortable with what's been said? Okay, thank you. We will, can I just, are these for noting, or are they, we don't need to vote on them. Thank you, oops, so sorry. Can we now move on then to the decision items, two decision items today, and the first of those being the proposed changes to the Health and Wellbeing Board terms of reference. So if I can pass over to you, Alison.
Thank you. Okay, well, as a Health and Wellbeing Board, we're required to review our terms of reference annually. So this year's reviews obviously had to take account of the changes that are being implemented as part of the Health and Care Act that was received royal assent in April. So we need to reflect the fact that from July, the ICS arrangements will come into place. So if you remember last year when we reviewed our terms of reference, we included the functions of the interim ICP into the function of the Health and Wellbeing Board. As the guidance around the Act stands at the moment, the Health and Wellbeing Board can't act as the ICP. So we're going to have to amend our terms of reference and take out any reference to the ICP functions. So Appendix A shows the terms of reference with the changes as track changes of the changes. And it also reflects the fact that the Act now requires us to take account of the 5-year plan for the ICB, whereas before the responsibility around obviously the CCG arrangements, now that's changed to obviously reflect it's the ICB from July. So the board is therefore asked to endorse the changes, because these changes will need to go through full council in September, because it will require changes to the council's constitution. We're also asking the board to agree some additional representation as associate members on the board. So we're looking to invite a representative from higher education and also a representative of the Greater Lincolnshire Local Enterprise Partnership onto the board as associate members. Obviously, with the ICP arrangements that are going to come into place later in this year, we had the workshop in April, where we looked at some of what the role and functions of the two bodies were going to be, and they're noted in this report. And obviously, there's a further report on the agenda around the ICS update. So that there is a clear ambition to mirror the arrangements as closely as possible in terms of the membership and aligning the meetings. So that's the sort of ambition that we're working towards for September. So really, Chair, I won't go through all the changes that are in the terms of reference document in Appendix A. I'm assuming that people have looked through those. But if I could ask the board to endorse the changes and to agree the additional membership so that we can present the changes to Council in September.
Thank you, Alison. Any comments or questions from anybody? Pauline.
Forgive me if I haven't read it all and I've missed something, but could I just ask how you intend, or if you are obligated to intend, to put this out to the public? And how do you do that? Do you do it? Are you obligated to do it? And how do you do it?
Very swiftly moving over to Alison.
We're not obligated to put the terms of reference to the public. No, the Health and Wellbeing Board is a committee of the County Council, so it's the County Council that agree the terms of reference of this board. I suppose I'm asking it wrongly then. I'm asking you about the ICS, the configuration of how you publicise the ICS to the public. Does that make sense? More sense?
John's going to pick this up.
Thank you.
Shall I just come back to that on my when we're talking, do my update on the ICS just later on the agenda, and I'll pick it up there, Pauline, if that's okay.
Yeah, sorry,
anyone else have any comments or questions at all? No? Right. In that case, can we move to the actions that are required on page 47? Don't intend to read them out, but can I ask you to agree action points 1, 2, 3 and 4? And I will just ask for, are there any objections? Are there any abstentions? In that case, that is carried. Thank you. Okay, item 8B is an update, well, the Better Care Fund final report. Glenn, would you like to introduce this?
Thank you, Chair, and congratulations. The Better Care Fund is a very familiar acronym to most colleagues within the room, and on this occasion, I'm afraid it's nothing more than just a roll forward year again, so not terribly exciting. However, I think what we might be able to say is that for 23-24, the Better Care Fund is expected to be materially different to that which it has been in the last 4 years. We understand that the government intends probably to use the Better Care Fund as the delivery vehicle for the integration white paper, which is currently going through Parliament. If that is the case, then the Better Care Fund will expand its profile and also its scope and coverage across the health and social care landscape, both in Lincolnshire and elsewhere. The value is considerable. The minimum contribution from the NHS in Lincolnshire this year is 62 million. Beyond that, though, as a system, we have for a number of years now reflected a much higher level of ambition than that, with in 22-23 a pooled arrangement in excess of 270 million. So it is a significant feature on our landscape. It is likely to grow in importance to us, and when we start to get the data and the details from government about what it might look like for 23-24 onwards as a multi-year settlement, we will bring that back to the Health and Wellbeing Board, ICP. I should mention also that there are a number of elements that are contained within the Better Care Fund, not least the pooled arrangements across mental health, learning disabilities, community equipment, but also a number of other areas that reflect the desire for increased levels of coalescence between organisations to better support communities. I think it's fair to say that in Lincolnshire, we are probably at the forefront at the level of integration and pooling that we have, but there is clearly far, far more that we can do. Attached to the report, there is some detail of the return that we are obliged to give, for which I'm grateful to Gareth, and also a copy of the letter that we received from government with respect to the allocation of disabled facilities grant monies to our district colleagues. As is our approach normally, district colleagues will have received that money within the month, typically, as a direct transfer. And that is also something that, of course, is of interest to colleagues who are on the health and care housing, health and care delivery group. I think I'll leave it there, Chair, and take any questions.
Thank you, Glenn. Questions or comments from anyone? Gareth.
So just to apologise to members, so in terms of the papers that were circulated, there'd been an error from the Excel spreadsheet being transposed into PDF. So Katrina's going to get out the Excel version of the return. I'm happy to pick up any questions people might have around it, or I can go into some detail on any of the elements of that return.
Thank you for that. Okay. And I think it's, well, thanks to the Health and Housing Care Group, and particularly Councillor Boquet, that we're in the place where we are as far as the DFGs are concerned, and with our district colleagues working with one another and making the best use of that funding, because it makes a hell of a difference to our residents, doesn't it? Okay. So, can we therefore, if there aren't any more comments or questions, can we go to the action required, which is that we are asked to approve the 21-22 end of year BCF return. Again, are there any objections? Are there any abstentions? In that case, I assume that's carried. Thank you. Okay, item 9A is our first discussion item, and John, it's over to you regarding the integrated care system.
Thank you, Chairman. Afternoon, everyone. So I'll just provide some sort of brief highlights of where we are with the development of the integrated care system, and then obviously happy to take any comments or questions as we sort of go through that. So I think the headline is, we're kind of teed up reasonably well at the moment, but equally there's just a bit of a scramble on to make sure we get all of the arrangements in place for the 1st of July when the new sort of statutory arrangements come in. So we all know that the new legislation went through at the end of April, I think, wasn't it? And that we're on track to establish the new integrated care system, statutory system, from the 1st of July. And there are going to be two, I think, new sort of statutory arrangements as part of that. The first is the establishment of the NHS Lincolnshire Integrated Care Board, and the second will be the establishment of the Lincolnshire Integrated Care Partnership. So as far as the Integrated Care Board itself goes, we're well on with finalising arrangements for all of the board members, but just a little way to go yet, just to completely finalise all of that. So I think you'll be aware that Sir Andrew Cash is the interim chair of the ICB at the moment. I'm the designate chief executive. We've appointed 4 non-executive directors, and they were noted in your announcements, Chair. We have appointed our 5th and final, and we hope to be able to make an announcement about that very, very shortly. We've appointed a finance and nurse director as well as chief executive, and we're in the final throes, hopefully, of being able to make the medical director appointment. We're equally just sort of finalising the arrangements for the 3 partner members from the local authority and from the trusts and from primary care, and also the mental health board member. So all of that is just still in the process of being finally sort of put together. And of course the board does rely on some really important support from sort of standing attendees, if I can use that term. So, for example, Derek, our Director of Public Health, has been confirmed to be able to attend the board regularly as well, which is great. The Integrated Care Board is an organisation. Obviously, it itself has the board. So when I talk about the Integrated Care Board, what I've just talked about is the Integrated Care Board. And the Integrated Care Board is required to meet on the 1st of July, its first day of establishment, to meet in public, and we'll be doing that. And that is really sort of quite a formal board meeting to complete the final establishment of the ICB as a statutory organisation. So that will include sort of formally agreeing the constitution for the organisation, all of our governance arrangements, reserved scheme of delegation, all of those sorts of pieces. So one of the first things I'd say, Pauline, is that this new ICB board will be meeting in public on the very first day of its establishment, although clearly that's going to be a bit of a one-off board meeting. In parallel with all of that, clearly we have to, or I have to, ensure that the CCG, which is the current statutory authority, is safely and securely closed down, ties up nicely at the end of the month, and we kind of seamlessly, those responsibilities and duties pass into the new ICB as part of the new ICB's responsibilities. So that's on track. As you can imagine, there's quite a significant number of concerns we have to attend to in relation to that, with our staff, with our duties, with our responsibilities. But that's pretty much on track at the moment. The CCG board itself is meeting tomorrow in relation to the accounts and audit for the CCG for 21-22, and the final CCG board meeting will be on Wednesday the 29th of June, just 2 days before the first ICB board meeting on Friday the 1st of July. Okay, so that's kind of where we are with the ICB board bit. In terms of the Lincolnshire Integrated Care Partnership, of course we all participated in that workshop in Sleaford a little while ago. Yeah, I left that feeling really quite encouraged and enthused about how we would evolve these arrangements together. There's clearly a really strong sense of not just collegiality, but the opportunities we want to seize on behalf of the people we serve together across Lincolnshire. I think, as we note, Sue, as we head sort of just a few months' time, we'll be able to confirm full establishment of the ICP, and then we'll sort of crack on with the arrangements. So I'm really quite comfortable at the moment in terms of where we are with those arrangements. And just to share with everybody that in parallel with all of this, there's a lot of work going on scoping out the evolving responsibilities of the Integrated Care Board. So to give you an example of that, from April 23, so next April, the Lincolnshire Integrated Care Board will have direct responsibility for pharmacy, optometry and dental services in the county, in the same way that we do for general medical services, GP services at the moment. So as you can imagine, those are hugely important services. It's key that we have a track where those responsibilities are safely and securely passed over to us. I'm happy to share with you that we're in that good place at the moment. I think we've got later on with the pharmaceutical needs assessment, so that's of even greater interest to me in that context. And I know not for a discussion now, but clearly there are a lot of issues around dental services and access to dental services in the county. I know there's a huge amount of work going on with that already, but I think we can expect that to come in sharper focus in terms of our local responsibility over the next 9 or 10 months. And then also to say there are other responsibilities which will come our way in subsequent years as well, in relation to specialised commissioning services, in relation to screening and immunisation, and in relation to health and justice services as well. Details yet to sort of crystallise and evolve, but just simply to say that if you to take all of these services together, then their value of the services amounts to about 25% of the total cost of what we spend on the people of Lincolnshire in NHS budget terms. So these are important services in their own right, but really significant just in terms of the size. There's a shed load of opportunities as well for us to integrate services differently and provide better care for people in Lincolnshire. So if I could just kind of finalise by coming back to Pauline's question about where we are in the public domain. Obviously, this is on the back of legislation that our representatives have voted through Parliament in the glare of the public and the media. Like all NHS organisations, the Integrated Care Board is a public organisation, and we have to work in line with all the very best standards of public probity and all of the rest of it. So not only will it be meeting in public on the 1st of July, but we'll have regular board meetings in public going forward, and obviously we're required to transact just absolutely as much of our business as possible in public. So that will be above board and for everybody to be able to see. Obviously, Sue, when we move into the integrated care partnership, you know, that'll be us, won't it? In the round, and we'll continue to operate in the public domain as we do now. I'm sure of that. My sort of own view, and I hope it's shared, is that clearly what's most important to the public at the moment is that the NHS is able to return and wherever possible improve on the standards of care and access that we previously enjoyed. So we need to be focusing on things like waiting lists, which are very, very significant, access to mental health, learning disability and autism support, cancer care, urgent and emergency care, how long people are waiting for an ambulance and in urgent treatment centres, A&E departments, and all of these other immediate issues, you know, seeing a GP, for example. So I think the public just really wanted us to get on with that stuff. We've got a lot of catching up to do, and I think all of us in the NHS are really, really sort of focused on that. In parallel with that, we, as Health and Wellbeing Board and ICP, and all of us as part of the integrated care system, have a responsibility to make inroads into some of the health inequality challenges that are so evident across our county. And clearly, you know, a very bright light was shone on that through the pandemic. To improve services where we can, to improve value for money for the taxpayer, and also to make sure that just the heft of our budget and our employment responsibilities is brought to the fore in terms of the overall, you know, economic impact on the population and our local economy. So those are the sorts of things we're really trying to spend our energies on. At the moment, whilst there may be some interest, I don't think there's much to be gained by having a public information campaign about how we're rearranging the bureaucracy around here. Clearly, you know, people actually want the health service to get moving forward again, as we are in all sorts of ways. But there's so much to do. So hopefully, Pauline, that answers your question. It's all in the public domain, but we're not going to be, you know, heavy-handed about changes in the bureaucracy. I'm happy to take any comments or feedback. So, thank you.
Can I say, yeah, I am on. Can I say thank you? And I suppose the reason I asked the question is obviously we sit on the other side and hear it, the public. I do run public sessions and hear it. And I think possibly, if I dare say it, the media have a lot to say, but not always in the right way. And so therefore it can be derogative to, I hear what you're saying and respect that. Possibly the public don't always hear it in the same vein. So it can be misconstrued. And you know, when you're in pain or caring or whichever side of the fence you're on, you view it from your own personal perspective. You don't see that bigger picture. So therefore, it becomes very much more difficult to sort of just accept. And the media don't see that, I don't think. They just sort of home in on, you know, you big guys at the top, unfortunately. So I thank you. And, you know, I know we work very closely with you and sort of try to balance that scale, if that's the correct way of doing it. I believe you're coming out to talk to us as well. And we do. The reason I ask is that I am running a public meeting soon, I think in October, which we are looking to possibly include ICS. And it's, you know, we'll talk to you about that, how to incorporate it in a positive way as much as we can. So I thank you and appreciate it. Thank you.
Thank you, Pauline. And just to absolutely emphasise that Healthwatch will clearly be a sort of trusted advisor to the ICB going forward, as it's been to the CCG, and we just continue to work in that really I think, important sort of vein as well. I must say that when I look at, I've looked at all of our waiting lists recently, yesterday actually, and when I look at how many people are waiting and how long people are waiting for outpatient and for their operation. Clearly it's slightly varied a bit across the specialties, but in broad terms it's absolutely dire compared to what our performance was like pre-pandemic, and it was pretty good pre-pandemic. Actually, our performance today by hour, it's not all, but significantly, Andrew and his team, we are marking very well by comparison to the rest of the Midlands region and across the country as well. And in fact, at the moment, we're being asked if we can also help out some other areas as well. So there you see both, a really good position comparatively that Lincolnshire is in, thanks primarily to Andrew and his team, but how much catching up we've got to do by comparison to where we were a couple of years ago. And I hear a lot from patients and their representatives in relation to that, and I know that Andrew will far more than I as well. So we're absolutely determined to do all we can to improve the situation, but it clearly will be a bit of a long haul. And similarly, in urgent and emergency care, so that's A&E and ambulance services at the moment, we see our staff putting in a monumental effort every day. Unfortunately, the demand and the challenges we've got is that we do fall short in terms of the experience and the service that we as it was prior to the pandemic, and we're determined to return to. So it is really, really challenging times. But I think we're very clear-minded on where we want to get to. And I think the trick is we just make sure that these new statutory arrangements don't frustrate us in delivering those ambitions. We take every opportunity to use them to accelerate the delivery of those. So thank you, Sue. Thank you, Pauline. I don't know if any colleagues, Andrew might just want to perhaps add to that.
Andrew, would you like to add?
I thank the Vice Chairman for that one. Yes, I mean, I think John's right. Pre-pandemic, the Lincolnshire system and ULHT in particular had a really good set of waiting list and waiting time figures. Has undoubtedly tailed off since then. We do compare well regionally and nationally, but as I always say, that's not a group you want to mix with, particularly because we know that those numbers on the lists and the amount of time they wait are other people's loved ones. So it's not about, oh yes, we're top of the pile. Just a shame people are waiting several months for their treatment. So I just wanted to assure people we never forget these are real people that we're talking about. People often in distress, in pain, in discomfort. And John's absolutely right. We've got to reduce the waits for those people. And it is the weights rather than the total numbers that matter. It doesn't matter if there's hundreds on a list if you all get done really, really quickly. And then the other weights are, as John rightly says, people waiting for urgent and emergency care, whether it's with us or anyone else in the health and care system. And last week, across the Midlands, was the highest ever attendances at A&E ever recorded. Now, it's one of those figures that Derek will now disprove on one of his many spreadsheets that he's got. But I do think it's an issue for all of us about why is that? Why are so many people calling ambulance and pitching up at A&E? There's only so much you can do with the volumes that you have. And for example, I think I was quoting figures last Friday. Lincoln A&E, for example, has got 28 cubicles. Last Friday at 6 p.m, we had 115 people in A&E, 52 of which we had decided to admit and had no bed for them. So those people wait in A&E, waiting for a bed. That gets rather crowded when you've got 28 cubicles. They're all full. more ambulances coming in. That just explains why you end up with ambulances queuing. There is physically nowhere to put people when you haven't got that flow through the hospital. So the waiting times really, really matter. They matter to us, they matter to John, but I hope they matter to everyone in this room, and I'm sure they do. And that's why we keep coming back to them. Thank you very much.
Thank you, Andrew. Councillor Wright, you had a question?
Thanks. So it's two comments, actually. One is in a bit of a response to what Pauline said recently with regards to media. And if ICS is going to be about us all working together and working across multiple strands, then make sure that comms is one of them and that we don't silo comms. I was in another meeting to do with health this morning, and it's about joint comms. You know, what was happening in a particular situation would have been far easily dealt with if we both sides had addressed it. Well, both partners, not sides, both partners had addressed that and stopped the media picking off one or the other for a non-story, because it was actually a success story, but the way it was portrayed in the media, nowhere near, because they always look for the top-selling bad news story, don't they? So I think that's something that has to be going forward. No, not one of us owns the story. We all own it collectively, and we'll be stronger if we do that as well. So half the situation we're dealing with, get the comms right to start with, and most of the problem disappears, and you can just get on with the nitty-gritty operational stuff. The second point is obviously what I brought from the districts there. I agree with you, John, that meeting was really good in Sleaford. Not all my colleagues obviously were there. It's just a request really that right from the start, as partners meet up for the new ICS, is for everybody to have an understanding of what everybody does and what the complexities of what we're dealing with. I think the worst thing is for any one organisation to turn up to a meeting and say, we've done a big piece of work, we've done a network, we've done some mapping, only to find out it doesn't overlay with everybody else's maps with the issues they're dealing with. One of them being in this huge, great, disparate county is connectivity. You know, we can put as many services we want in certain places, but let's hope everybody can get to them. And quite often it's the practicalities that have to be addressed, as well as clinical need and solutions. So it's just about hoping that right from the start there's a recognition of what's needed from across the piece.
Respond to that. I think that's a great point, Richard. And you know, as we move into these new arrangements, it's called an integrated care system. The point isn't, in my mind, to have a system. The point is to have integrated care, and that's care, I think, in two ways. One, in terms of individuals going through the system, that they get joined up care, but it's also integrated care in terms of our collective care and responsibility for the health of the communities that we serve. And from that session we had in Sleaford, what I took from it is that if we're going to improve and address some of the health challenges we've got, everybody's got a lot that can play into that. And the key will be us all recognising that and making sure that people work together, quite often on a very local level in relation to that. So whether the issues are to do with housing, to deal with young people's health, to do with obesity, to do with smoking, to do with physical activity, to do with education, to do with loneliness, all of these, the solutions to that they certainly don't lie, in the NHS. It relies on, the respective responsibilities and roles that local government, both district and county council have, that our third sector colleagues have, that the care sector has, and others sometimes, like the police or colleagues in education, whatever it happens to be. And I think there's a great opportunity, isn't there, for us to make sure that the sum of the parts is greater than just the components, because we've all got a huge amount to contribute to this. So that the trick we need to pull off, I think, is actually creating that to maximum effect in terms of how we support and improve the health of the population, which is a slightly separate issue, of course, isn't it, from the internal workings of the NHS. But clearly, the more we can do on that front, the more it will enable people to live well and healthy lives in local communities, and hopefully, to some extent, we'll be able to reduce the impact and the burden of whatever circumstances people are living in on the NHS going forward. So we've got to pull off I think both tricks in terms of integrated care, joined up care for individuals, and that broader care for the communities that we serve. Points you make about comms and media, spot on and noted.
Councillor Bowkett.
Thank you. Well, John's just stolen my thunder, unfortunately, and it's not very often I do say that about him. But it is about us working together. I mean, John and I have been working. I went round Lincoln County with Andrew and Elaine a few weeks ago to see on the front line what it's like. And yeah, it is scary in A&E. And that was a quiet day that they, don't know how I chose a quiet day, but I did. I think they'd got them all piled up down past the prison and they weren't letting them in till I'd gone. But it is about us all working together now. It's exciting times coming up, I think. I'm excited about it. We have got a great opportunity of working together, but we do need to work together. We don't need to go off in silos. So that's districts, county, health, everybody, mental health, Maz, Pauline, everybody's working together. We've all got a place in this and we've all got a journey, but we do have to make that point of working together. And as I say, not going off and finding that, oh, well, they're doing that over there. Why are they doing that? Because we've already got that there. So it is about everybody listening, what we're all doing, and I can't wait to get started.
Yes, I think that this conversation around the working together, we've got to try and make sure that we've got in our heads the default position is whatever it might be already out there, because we often find that there are pockets or organisations that are already running with something, and then we go and set up something new, and it's that just checking all the time that there is something, and if it's working well, we run with it. We don't set up something fresh. I anecdotally remember some time ago that we always seem to want to map things in whatever organisation it might be. The first thing we've got to do is map what's already out there, ignoring all the mapping that's gone on before. And it's just that, come on, have we got something that's already fit for purpose, and that each of us as an organisation is comfortable using. So it's not difficult stuff, but it is something that we just need to keep reminding ourselves. And indeed, those that either work within our organisations, or in our case, our fellow councillors, etc., and making sure that we sweat that penny and that pound as much as we possibly can in this county. Okay, anybody else? Thank you, John. We will now move on to our next report, which is the Let's Move Lincolnshire Physical Activity Strategy. Emma.
Thank you, Chairman. Hi, everybody. Emma Tatlow from Active Lincolnshire. I'm here with my colleague Lorna. Lorna's going to chip in and help me answer any of the questions that we might get towards the end. Obviously, the slides have been presented in your pack, so I won't talk through them slide by slide, but we'll just use them as a bit of a prompt, and I'll talk through where we are at in terms of the Let's Move Lincolnshire strategy. So I might have to keep saying to Katrina, next slide, please. Thank you. So just a reflection in terms of where we're at. If you could move on to the next slide, Katrina. The Let's Move Lincolnshire strategy was launched in 2018 as the physical activity strand of the joint health and wellbeing strategy. And clearly a huge amount has changed since 2018, not least the pandemic, that has had significant impact on the health and wellbeing of our population, but also on the physical activity sector. Also in 2021, Sport England, the national organisation for physical activity, refreshed their strategy and launched Uniting the Movement, a 10-year vision for us to all understand how we can support people across the country to be more active. Sport England is our primary funding organisation. We've just agreed a 5-year commitment with them. They fund an organisation like us in every county across the country, and that funding commitment is £2.6 million over 5 years. Sport England have significantly changed their direction, particularly in terms of working with active partnerships such as ourselves. They are now funding us to be a system partner and to particularly focus on tackling the challenge of inactivity. So we're not funded to help sporty people be more sporty. There are NGBs and lots of other organisations out there to do that. We are funded to really try and shift those inactive people to help them to be more active. All of the work is absolutely underpinned by the focus on tackling inequalities. So recognising that there are particular communities, people with disabilities, long-term health conditions, minority ethnic communities and women and girls who we know are significantly less active than others. So whilst I think we all obviously aspire to have a universal offer that anybody can access, where we can focus our resources into particular areas, it will be on those audiences that we know are less active. And Let's Move Lincolnshire is really all about understanding how we can remove those barriers to participation in line with local need and understanding what we know of the audiences and the places of Lincolnshire and the challenges, not least rurality, that we face. Next slide, please, Katrina. So we've been working with the University of Lincoln since September last year to really kind of unpick and understand the Let's Move Lincolnshire strategy and work out where it needs to be for the next 10 years. This is very much a 10-year vision. It's not going to happen overnight. The Active Lives data has shown us that actually the challenge of inactivity has been a significant one in the county of Lincolnshire for around a decade now. But nevertheless, we feel that through this strategy, we can start to really shift and make some significant change by working in partnership, by collaborating across the whole system and recognising that everybody has got a role to play in enabling people to build physical activity back into their daily lives. So I'm going to come on to the themes, which are the kind of 6 boxes, across the middle of your screen there. I'll come on to those next, but just wanted to talk about the guiding principles really that are holding all of those themes together. And again, we come back to communication. It's been mentioned a number of times now, and we know that it's a challenge and an opportunity as well in this space, both in terms of collaborating across the system and across the partnership, but also in terms of how we communicate to our residents and enable them to understand how they can be active in this county. EDI, and particularly that piece around tackling inequalities, again, needs to feed through all of these themes here and is a significant part of our work, really trying to understand those audiences that we know face greater barriers to participation. And importantly, of course, it's understanding how we evaluate this work, how we're led by data and insight, and then how we evaluate and understand the impact of the work and share those measures and their learnings across wider system partners so that everybody can learn from the good work that's happening. Next slide, Katrina, thank you. I'm not going to talk about all of the themes one by one that sit within the strategy, but I just thought, again, it was helpful to kind of reinforce this point around physical activity isn't one person's job. It's certainly not just about the football pitch on a Sunday morning or the gym after work. It's actually about how we can understand how to better connect communities. We know that more active communities are more cohesive communities. We will see reduced crime rates. We understand that physical activity can contribute to the net zero and the carbon neutral agenda, for example. We also really understand that active environments are absolutely key. So when we did the research with the residents of Lincolnshire, safety was a huge barrier and people just not feeling safe to cycle on the roads. In fact, anecdotally, I think a really interesting example is of a care agency who during COVID had their care workers cycling around Skegness to do house visits, 5-10 minutes on the bike to hop from house to house. Post-COVID, the traffic's back, there's a lot more cars, buses and trucks on the road, and actually now those carers don't have the confidence to cycle around to do their house visits by bike. So it's us understanding how we can inform and influence the decision makers across all of our organisations, from planning to highways to parish councils that are thinking about what they do with their public spaces. And importantly, of course, connecting with health and wellbeing, and we'll do a little bit of a deeper dive into health and wellbeing through this particular presentation today. Next slide, please, Katrina. You can actually skip on the next two. And the next one, yeah, there we go. So just, again, touching on insight, again, these maps will look, I'm sure, very similar to all of the data that you're looking at. This is the inactivity data, the red spots being those most inactive populations. But really importantly, again, I just want to remind the people in the room in terms of how the data shows us that of people with disabilities and or long-term health conditions are even less likely to be active, and 74% of those people are not meeting the guidelines of physical activity. Again, a very interesting conversation of a mother with a severely disabled daughter in a wheelchair who cannot access her local park because not one of the things in that local park is available to her as a wheelchair user. So thinking really about, you know, the whole system and how we can really ensure that everything we do is inclusive. Next slide, thanks Katrina. And we're starting to get a lot more data available to us through a platform that Sport England have invested in to understand actually the social value and the cost savings essentially that physical activity can have back into the health system. So the current data through the Moving Communities platform is showing us that the social value generated at leisure centres through the last 12 months is £1.2 million. And again, there's some statistics here that are still building, and I think as this data continues to build, we'll start to see these numbers increase significantly. But of course, we recognise that if people are more active, it's going to help them with mental health, with their long-term pain, hopefully reduce the pressures on the healthcare system that, as we've heard today, we recognise the whole system is facing. Next slide, Katrina, thank you. So during our consultation, we talked to a huge number of stakeholders and residents. I think there was close to 400 individual people in total that have fed into this piece of work. And these are just some of the highlights. So this isn't what we think, this is what people have told us and what they've said that we need to address through Let's Move Lincolnshire. But again, conversations here today around that connectivity and engagement across stakeholders and across system partners, and a feeling that still we perhaps have got some more work to do to better build those connections and that connectivity and make sure that we're not duplicating efforts. To make sure that we are ensuring that our budgets are all aligned and not conflicting. And I can say that absolutely being a charity, there is sometimes competition within the sector, you know, within the county that doesn't necessarily need to be there. So it's understanding how we can work through that and give people the confidence that we don't need to compete internally, but actually we need to collaborate. A lack of awareness on all of the work that's taking place across physical activity. And you know, we recognise that we as an organisation have got a significant role to play in that space to actually better communicate what's happening across the piece, because there are a huge number of partners and collaborations and community groups involved, everything from the commission services down to the really local level community activity that's going on. And we need to be able to better communicate that whole system around physical activity and not just the individual parts. A need for that centralised resource and to think about how we can build back those connections and those networks, and also a real steer to suggest that we need to be able to support and educate clinicians, carers, everybody working in the healthcare system, for them to be able to better promote, utilise and have that conversation around physical activity in their day jobs, essentially. So I'm not going to dwell on, next slide, Katrina, thank you. I'm not going to dwell on the actions of all of these, but again, I think the purpose of this is to actually say stakeholders are very kind of comfortable. Yes, there's a strategy and that's wonderful, but actually what are you going to do about it? And what's the action plan? What's all this kind of stuff going to look like? So Lorna is really leading on building now the action plans around this and understanding what the next 1 to 3 years look like, and then that kind of horizon planning, where do we need to be 10 years in 10 years' time. That it did seem to be a need, Chair, around the gap analysis, but again, recognising that there's a huge amount of mapping already, but actually, yeah, just understanding where those gaps are and bringing together the existing data and the existing mapping, and really understand, again, aligned with the work of the ICP around the kind of that local level neighbourhood activity, and recognising that all of our neighbourhoods are slightly different, and how we can work in those neighbourhood areas. Next slide, thanks Katrina. I think a key one for the people in this room is around the workforce development, and there's two sides to this. There's the physical activity workforce. We need to ensure that people working in physical activity who are providing services understand the needs of our population. That might be people with various long-term health conditions and disabilities. At the moment, we absolutely know that there is a very good mainstream offer, but again, to really support those people that have got long-term health conditions, actually the physical activity sector need the support to be able to offer those direct services. And again, coming back to people with disabilities, we recognise that your average leisure centre doesn't particularly well at the moment cater for people with disabilities. Then on the other side of that, we've got the healthcare sector and how we can ensure that we are informing, upskilling and educating everybody that's working across the health and care sector to have those conversations about physical activity. So every time there's a touch point with a patient, it could be a GP's appointment, it could be a letter that's coming through from the Mental Health Trust. There are so many touch points that are reaching our population where we genuinely can see there's an opportunity to start stitching in those nudges and the communication around be more active. I think this can absolutely start to address some of the challenges around the waiting list, and where people are able to do so, to be encouraging them to stay healthy and to move more whilst they might be waiting for an appointment. Next slide, Katrina, thank you. The work around connected systems, again, absolutely thinking about how through specific pathways, we're doing a lot of work in pre and postnatal at the moment, absolutely is a collaborative. And there are so many touch points for people on that particular pathway that we need to make sure that across the system, the messages are consistent and that we have a really patient-centric approach to how we understand how we deliver those messages around people being active in whatever pathway they might be in. And there's some really interesting work, that is going on in other areas in terms of active GP practices and active hospitals, and making sure that our facilities and where people are being seen are really enabling them to be more active. Again, we recognise the barriers. People that are inactive and not particularly thinking they're interested in activity at all are very unlikely just to walk into a leisure centre, but they're very likely to be in a GP surgery, and it's how we can start to build those connections between the places where we know the target audiences are going to be, and how we can encourage them to be active in slightly different ways. Next slide, Katrina, thank you. And then the final action around this kind of piece of work in health is that narrative building, to create that shared voice, to ensure that both the system and the workforce again understand what's suitable, what's safe, give them the confidence to have a conversation about physical activity, and also to ensure that our residents are really aware of all of the options to be active that there are going on across the county, and again that it's not kind of lycra clad, really high intensity exercise, but actually we just want people to get out there and to be active, to walk with their dogs, to play on the beach with their family, to do yoga in the park, whatever it might be. It's really showing people that kind of whole range of activities that are available. So how can we build on the communication platform to be able to co-own and actually deliver better messaging to our residents, and again get better value for money in terms of the investment that is going into communication currently. The next two slides, thank you Katrina, are just to sort of give you a highlight of some of the work that we're doing as Active Lincolnshire in health at the moment. And I'm not going to talk through all of these, but what we are able to really evidence now is that this kind of work at quite an intense level across some of the pathways is really starting to make a significant difference, and we think there's quite an opportunity here to be able to kind of scale up this work, scale it out across different pathways, across different parts of the system. We're very much testing and learning at the moment, lots of work here on kind of a pilot level, test and learn type level, and we really now want to be able to kind of take this so that we can scale it up, so that we are embedding this across the whole system and it just becomes a normal part of people's behaviour. And actually that enables us to create that sustainability. If the workforce, if the places that people are moving in, if the systems that they are using and engaging with are enabling them to be more active. That becomes sustainable. If we have to keep funding a Sunday session for, I don't know, walking football, for example, you know, then there's a real kind of challenge for us there in terms of how, sustainable that kind of work is. Next slide, Katrina. I think that's, again, very similar, just, some examples there of the work that we've done. I won't talk through all of those, but actually the Tackling Inequalities Fund, which was additional funding from Sport England we received during COVID and are still receiving now, has helped us to support 58 different projects that has actually reached thousands of people, all absolutely focused on people that face greater barriers to participation. And again, we're seeing some really great examples here of organisations that actually probably wouldn't have been delivering or considering physical activity in their work, and how we can start to support and influence and inspire them to think differently about the provision that's available. I'm going to leave it there. I think the final slide is just a link through to letsmovelincolnshire.com, which is the club and activity finder, integrating with connector support and lots of other platforms that are out there, recognising again that people might not visit Let's Move Lincolnshire, but they might be visiting a healthcare system partner's website. They might be looking at connector support. They might be looking in all sorts of other ways. So we're sharing that information through widgets and other kind of tech, so that we can get more eyes on that content and provide more opportunities for people to be more active. A whistle-stop tour, but very happy to take any questions. Thank you.
Thank you, Emma. It certainly was a comprehensive report. Councillor Rawlings.
Thank you, Madam Chairman. Thank you for your presentation, Emma. It was very interesting. My sort of overall question would be, would you agree that catching the young and influencing their decisions not only affects them, but their parents and probably their elderly relatives as well? And going on to your next paper, the next paper on obesity, probably the same issues apply. So how will Active Lincolnshire communicate through the education system? Because certainly in junior and primary schools, I mean, going back to, I'm in my 60s, so going back to when I was young, it was compulsory physical education, and it was just, you had it constantly all the time, both in primary and secondary schools. And I think that, you know, you set up a lifelong sort of core fitness. So now I know the temptations of modern life and the situation is completely different, but it all started off at school.
Thank you, Chair.
How we're communicating to the education system.
Yes, absolutely. Brilliant question. One of the key themes within the strategy is focused around children and young people and providing positive experiences. And I'm sure I'm not the only one in the room that might have had a fairly unpleasant experience of school PE, which kind of puts you off PE for a certain, or for being active for a certain period of your life. So focusing around children and young people, absolutely. Heather and I were just having a conversation earlier, and for us it's about how we can inform and educate the education sector. They're not only the PE teachers, actually it's got to be the head teachers, thinking about active curriculum. You know, there's all sorts of really exciting stuff you can do teaching maths through physical activity, for example, so it doesn't just have to be focused on that 60-minute PE lesson. We recently heard of a secondary school actually in one part of Lincolnshire, and the children attending there are still only getting one session of PE a week. So it's thinking about how they can travel actively into school, how they can be active as part of the curriculum, and for us it's to work through partners like Lincolnshire County Council to ensure that we are informing, inspiring and educating that network. We ourselves run the school games, and actually I was having a conversation with the chairman this morning about the work that we're doing around school games. So again, even that is moving from providing a competition for sporty children to perhaps take part in 100 metres or a high jump, and we're really focused and targeting on those children who may be obese, who may be struggling with mental health issues at school, who may be struggling with transitioning into secondary school, and providing a non-competitive environment for them to engage in physical activity and thinking quite differently. So they might get involved through dancing or skipping or boxing or whatever it might be. It's not something that's going to actually give them that, negative experience that could put them off. And I think importantly for us as well, the work around children and young people has got to be not only in schools, but it is about influence in the family. And that's when it comes back to we need safe spaces and communities for families and for children to play. And play is so important. 50% of the children in Lincolnshire are currently not achieving the recommended amount of 60 minutes of activity a day.
Thank you, Emma. Councillor Richard Wright.
Thank you, Chairman. Yeah, talking to colleagues, everybody thinks it's a really good piece of work, and the fact that the lottery, Sport England, well, they get money for the lottery, don't they?
Yes, they do, yeah.
Are paying for this instead of St George's football training ground for the England team is very appreciative. Just a couple of questions really. Is one that when you're talking about the information gathering and mapping, then Social Change UK did an awful lot of work on nudging before the pandemic. So has that been sort of utilised? And the other thing is regards to there's a lot said about enacting, getting people off getting people off the backside, getting them onto the feet. Is that how is that done, and how do we keep it going? So for instance, I swim quite regular, and there was a gentleman started swimming a few weeks ago, paid for by the GP because he had a weight issue, lasted 2 sessions. That's it, because there was nothing really in place to keep him, apart from people talking to him, but obviously we're not trained professionals to give him that encouragement, but so that stopped. You mentioned walking football, and I know before the pandemic that the 2 fastest growing sports in the UK were walking football and walking netball. It's outstripped anything, but that's what one of my colleagues referred to as health by stealth, because nobody said you're old and overweight, you need to get down. It was all about meet a load of mates. It's a great social thing to do. You meet loads of people sort of in your age bracket, good night out, job done, and of course that's health by stealth. So how do we encourage more than that? Because sometimes the direct messaging, people are turned off from it, aren't they?
Yeah, thanks, Chair. Thanks for the questions. Your first point around social change and the mapping, yes, absolutely. We're not talking about new mapping. It's about gathering all of the information that's there already. Social change are on the board of Active Lincolnshire, so we have a really good relationship with them and keep very close to the work that Kelly and her team are doing. For me, I think the conversation around how do we get those inactive people active, it is that health by stealth piece, and it is making sure that there is a relevant and appealing offer available across the whole county that people can easily access and easily tap into without thinking that they're going to a gym or that they're going to be physically active. Quite often the motivation might be because people want to make new friends, or because they want to explore the wolds, or because they want to get out and see the countryside, or they want to spend time with their family. So I think it's about us influencing the partners across the system to make sure that there is enough of a breadth and depth of physical activity on offer that's genuinely kind of built into the community and is readily available for people. And again, I come back to the things around safety and the open spaces and safety of our streets and decisions that we make around highways and planning. And actually, if it's relatively easy for somebody to walk or cycle 2 miles to work or to school, perhaps they would do that. But when they feel that it's not safe for them to do so, they're going to default to the car. So it's building it in at all of those points across the system. And that's why, certainly from Active Lincolnshire's perspective, we're really focused on how we can influence all of those system partners to think differently, to enable physical activity to be built back really into everybody's daily lives. Does that answer your question? Yeah. And in terms of walking football and netball, sorry, I know, Links FA, equally funded by Sport England, with a huge focus around tackling inequalities. So whilst they will continue to provide and offer their mainstream football offer, actually you'll find now that the NGBs are also really focused on how their investment and support can be used to help people facing inequalities. People like Lincoln City Football Club are also doing a great job in that area as well. For us, I just think it's about the breadth of the offer and the coverage of the offer. Your point around rural issues, transport and isolation earlier absolutely applies to physical activity. If you live in the city, if you live in some of the the larger villages and towns, you might have access to things, but for the people that are in the more rural parts of Lincolnshire, they could have a good half-an-hour drive to get to the activity that they want to see. So it's absolutely how do we build it into the community as well.
Councillor Murphy.
Thank you. I've sort of read this and listened to what you said, and then I went Googling onto the websites to see what actually Let's Move and Active Lincolnshire, and it does get confusing. I mean, Let's Move comes up with more property choices to go and move into Lincolnshire as all the ads, and then you end up with two websites under each other, which then end up flicking you into the other one. And it's one of those where I'm like, okay, roll it back a bit. In a sense, the wealthy people and those that are what I call active crack on and actually, you know, let's face it, every school finishes at, say, 3 o'clock, 3:30, and actually, unless you're in a privileged position, you will not be taking your kid back from a rural location to go and play hockey, and they're the bound. You know, it's the barriers actually is my concern. The barriers are huge and deep. Being able to, you can't catch a bus on a Sunday to go and do any sport anyway, even if you are a youthful, energetic person. What I didn't see much in there was business, no sort of reference to sort of the business world, and actually quite a lot of businesses are pretty good at starting to sort of put sort of facilities within their own workplaces. I don't think we've quite got one here yet, but at least you can have a shower if you come in here. And, you know, it's those little things, isn't it? People actually quite like to bike, but if you're going to arrive all sort of sweaty from exercise or sweaty because it's been raining, you need to actually sort of clean yourself up before you start. And I get what you're trying to do on connecting, in effect, those little things like facilities to just actually help people do it. There is a big transition shift. I live in Tealby, and actually the invasion by everybody coming to walk is huge, to the point where we sort of actually can end up now with traffic issues, and no, if you leave as a local, you'll not get parked when you come back. But it is predominantly older people that are walking, except for last weekend. Duke of Edinburgh Award is the most amazing thing to get kids back out in the countryside walking. And actually they do come in the droves to Tealby because they all sort of packed off, and they were from Branston all over, they camp. I would actually have Duke of Edinburgh inflicted on every child in any school, because I think the positive outcomes of that, you know, most of us go away and have a great time and a disaster in camping or something happens, but that's life, and we all look back and laugh, and at the time we perhaps hated it. And I know my kids are active, and actually I dragged them to every event and they hated it. And now they lead by example. And often I look at my parents and how they did it, and I think we do have that sense that we don't necessarily like it. I run every day and I think, God, I hate running. But it's sort of, that's the barriers, isn't it? And I think you're on the right wavelength. I bring business and more that sort of what I call the sort of economic sector into it, and I'd try and focus somehow, but I think it's sort of really getting that really understanding of what stops people. I mean, I drive past Market Rasen, we've got a park there, it's got facilities in it. You very rarely see people in, you perhaps see people go. And one last thing, I think what really often causes the blockers, if you look at go on whichever site it was on, Let's Move. For my area, it all came up, Market Rasen Gym, all the sessions. And I tell you what, everyone looks fit and healthy, and they're shining beacon of how a body should look. And I'm thinking, well, if you're really trying to get back in, that comes a blocker. And actually, I think you need to stimulate more what I call, you know, budding, as in between, let's say, 5 and 6. It's a session zone where actually those that aren't healthy can come, and they're with their own lot. And we all join up with our own likes. And I think that what we perhaps don't ever do, and I've looked at this for years, we never, you know, if somebody is really overweight, they're not going to go to a gym where they might go and use some of the equipment when they get shown, but they're never going to go to an exercise class where everyone gets on a bike, sweating off all over the place, and, you know, because they're not going to last 5 minutes. Even I perhaps wouldn't do on certain. So I think it's sometimes we need to, I hate to say it, categorise sessions around, because then the people that all go there start to help and buddy up and support each other, and they keep the momentum going, because it's actually, it's not just getting people back into doing it, it's keeping that whole momentum and drive. And I think sometimes we don't like to categorise, but you actually, if I wanted to get back into shape, you actually want somebody that's like me or somebody that drives me on, either or, isn't it? But what I don't want to be is in a situation where I'm completely outgunned and outfoxed by somebody and losing all the time because I have a sense of humour and I won't do it. And I think sometimes it's there, the barriers that sort of to break down, and then it sort of opens itself up. But yeah, good luck with it, I think.
Was there a question there, Hugo?
I think the question is get the business in. The rural bit is it's always a challenge. I think the whole project's a challenge to really, you know, there's so many areas that you can go in, and I, you know, I'm a sports fanatic, by the way.
Yeah.
When I retire, I'm sat down with my Sky TV and watch sport all day. But
yeah, and I think, you know, all of that is just absolutely identified, hasn't it? The complexity of the system and the complexity of the challenge that we face. You know, we've touched on the surface in a few minutes here of talking you through the presentations. We are acutely aware of a number of those issues and are trying to work again with system partners across the piece to understand how we address those. We haven't got the communications right yet. We're working on it, and that absolutely needs to be addressed. And as you say, in terms of the image and the presentation of the images, you know, that's for us again to work with the physical activity sector and to get the leisure centres, for example, to recognise that we don't all want to see, you know, extremely fit-looking people in lycra on the front of their brochures or on their adverts and so on. And that is absolutely all work in progress. We're not there yet. We've got a huge way to go. In terms, if I can just address the piece around business as well. Again, Lorna and I have had a number of conversations about this recently. We recognise that the strategy at the moment doesn't identify that, but as an organisation, it's an area that we've had a number of conversations with the LEP with. I'm at a Team Lincolnshire event at the end of this month. Everybody's welcome to attend at Butlins. We're presenting to the Team Lincolnshire members, to the private sector, to start talking about how they can support their own workforce to be more active, and how also investors coming into the county can think about their corporate social responsibility to invest in community spaces to enable people to be more active as well. So I agree that it didn't come through in the presentation today, but it's very much something that we are considering. But yeah, thanks for your comments, and yeah, absolutely. I think that just shows the complexity and the scale of the task.
Thank you, Emma. Maz.
Thank you. So being somebody who has driven to Tilby, and I'm not doing Duke of Edinburgh, I'm clearly in the elderly category now, I think. So that's put me in my place, I think. So just some comments, please, if that's okay. So just talking through, I think absolutely right, take on board your comments about the platform and the navigation. Not everybody has access to that, but we have venues where we can really promote, and that's not only GP practices, that's community hospitals, that's community settings. And I think you're absolutely right that volunteers play a huge part. So in my organisation, particularly patients who have had a heart attack, we use, and they do the walking football, and they are our greatest and biggest advocate of getting new people to start being active. It's not that person in a clinical outfit that gets them and encourages them. So I think there's a number there that we've absolutely got to grow. The digital bit for me is about how do we make every contact matter, sort of that MEC. And I think there's about a digital platform or a digital app that we create in Lincolnshire that all of our colleagues can access, irrespective, health, voluntary sector, care. Because I think that's the bit for me. They don't have time to navigate in their day-to-day world, but they want to provide the right information to their clients, their patients. So how do we make that easier? How do we pass that on to people's families? And I think there's something about platform branding that actually we pull all this together. And our workforce are probably at times really inactive. And when we think about the collective workforce that we have in this room, how can we use them as a real advocate to get in? How do we create that in our culture? So the Lincolnshire People Board is revising its health and wellbeing strategy on behalf of the system. And I think there's a real linkage linking you into Kerry Lennon around that actually, if we got our own people active, because they're the people who are also accessing our services. So thank you.
Thank you, Maz. And I think you're absolutely right around that. Certainly for me, for the system, and that means for all of our residents that live in Lincolnshire, we need one go-to place. You know, I know we're promoting Connect to Support, but the point is, it wouldn't matter what it was called, that it doesn't matter whether you're a resident, a GP, whatever, that you can see what's available in your area, and you can refine that search all the time, so it's there and it's in one spot, and it's easy to be able to get to. John.
Thank you, Sue. Hi, Emma. Hi, Lorna. Just firstly, say I think this is really good. So I think you deserve our sort of full support in taking this forward. And sort of, what it was about 6 months ago, Emma, you hosted that sort of celebration evening, didn't you? Awards event on there's some brilliant stuff happening across our county. It was superb. So there's already a massive amount going on in relation to this. So you're clearly at the sort of beginning of this next phase, aren't you? So I guess the question, perhaps to take away rather than to over-explore now, is what do you need from us and what do we need from you so that we succeed together on this? Because physical activity is woeful in the county, isn't it? When you look at our overall figures compared to the rest of the country. The second one is about connection. So how do we make sure it's connected in to, and I don't really know, but I mean, obviously 1U and all of the other PC, district council, leisure services, all of that. I'm sure that you're both connected in, but also would like to be more connected in with more as well. And the third one is about integration as well. So how do we make sure that the offer that you develop is alongside and integrated in with and fits well with other offers rather than is either competitive or a silo apart from other offers which might themselves be in a silo. So I think those are the things I'd be looking to, or suggesting we do some more thinking about how we help each other out, how we make sure it's all connected up, and how we make sure it's truly sort of integrated, so we go back to making the sum of our parts really count. And then a bit of a subtext, but I think I and possibly Andrew and Maz and Sarah in the NHS, we might just be interested in a conversation about what an active hospital or an active GP practice or whatever could potentially look like. So perhaps I'll just leave those thoughts with you, Emma, and we'll take things forward together.
Okay, thanks for that, John. And finally, Pauline.
Thank you. Thanks. Brilliant presentation. I just see that in your, you have the equality, diversity and inclusion, and you have that as a working group. And I'm wondering if you could include something into that, so patient and public involvement and engagement. And so therefore you start to connect communities right at their ground level, but you sort of are making it not formal, but you are making it formal. So connecting people in, then you're taking them direct into their communities. So it does take a little bit in of what Councillor Marfleet was saying about, everywhere's different, but they connect in and they will take your voice directly into where they are. And it has a formality to it, but it also works in and out. So I don't know whether do you include that in a formal way, patient and public involvement?
Sorry, I hadn't realised we could only do one at a time. That's why, sorry. Yeah, thanks for that. We're actually looking in terms of that group of engaging with people from the community to sit on that group. And again, a huge amount of our work now is recognising that if people like us are the ones making the decisions, actually then we're not reflecting the genuine needs of the community. So it's absolutely about how we get that community voice, but also working with Sarah and the team at Health Watch and for us to gather that information and insight, because we recognise that there's a huge amount of community engagement going on already, and it's not always best for us to go into a community and have a conversation about physical activity. It might be actually about going in to have a conversation about community cohesion, and one of the outputs of that is around physical activity. So yeah, absolutely. Thank you.
Okay, thank you everyone. If I can take you back to page 89 regarding the actions, and that's for the Health and Wellbeing Board to approve the direction of the strategy refresh and specifically the health and wellbeing actions. Is everyone in agreement with that? I can see everyone nodding. Yep. And anyone against? Any abstentions? Okay, thank you for that. Thank you, Emma. Move on to our last discussion item for today, and that is item 9C, which is the childhood obesity strategy. Not strategy, just about childhood obesity, isn't it, Andy? And you are going to speak to this. Derek, are you opening, or is it straight to Andy?
I'll just do a quick opening, if that's all right. It fits very much with what Emma was saying. Also, the things that have been mentioned, we talked about one new Lincolnshire, which the Health and Wellbeing Board will know, is our integrated lifestyle change provider. Covers very much people who are maybe waiting for surgery or have pre-existing health conditions, to help them become more physically active, to quit smoking. But it is focused at working age adults and older adults. It doesn't cover children and young people. And so what Andy's going to talk about is a little bit about what we know's happened, or what we suspect has happened in Lincolnshire anyway, what we know's happened across the country, given the COVID pandemic, how we need to support our children, young people and families to recover well from that, and how we can expand and extend the environment within which families can be more physically active, to try to tackle some of the obesity challenges that we know are going to come through. And I think it's really important for us to focus on, what we want to focus on is healthy weight, not obesity. And we've taken that view as a Health and Wellbeing Board, and I'm sure we will through the ICB and the ICP. Let's focus on how we keep people fit and healthy, because we're spending an awful lot of money on dealing with the outcomes of not doing that. So this is one of the ways that we want to try and help our children, young people and families to focus on healthy weight. On that, I'll just pass over to Andy.
Thank you, Chairman. Thank you, Derek. So, yes, I'm going to talk you through this report here, which I'll take as read. I'll draw out some of the highlights, and I'll just indicate some of the plans that we have for trying to address this. It does very much mesh with the previous conversation discussions. Those points are very relevant here. So we're talking about childhood obesity, and we're looking at the latest release of national data around the National Child Measurement Programme. For those who aren't aware, this is where children in school are measured at reception age in year 6. This is primary age children, and it's a fantastic source of epidemiological data, essentially on the state of health and well-being around weight in the country. Very, very good, reliable data set that we get every year. So we get a good sense of how things are changing in the country. This is the first release of data since the COVID pandemic, and a couple of points to make very clearly. Firstly, that this is national data, that obviously during the pandemic, the National Child Measurement Programme wasn't mandated. And I remember Heather and I having chats, and Martin Smith. And so just to be clear, that we didn't want schools to have to cope with the National Child Measurement Programme during the pandemic. There was plenty going on, and we wanted to focus on getting all the children into school that we possibly could. So we certainly didn't try and get that to happen in Lincolnshire. So that means that Lincolnshire's data weren't recorded in this period for 2020-2021. What that means is that this is national data, and it also means that the sample size, essentially, the number of children who were weighed and measured, is far smaller than it would usually be. So instead of 95% of children eligible being weighed and measured, it was 75% in 1920 and just 25% in 2021. Now, there's still a lot of children when you're talking about the numbers nationally, so we still have good statistical confidence that this represents the picture nationally, and that's an important point. However, the Office of Health Improvement and Disparities that now releases data do say they should be treated with some caution. So more caution than previously, but no reason not to believe that these data represent the true picture nationally. And obviously, hence the paper, the data show a deterioration in child health, an increase in the prevalence of obesity and severe obesity. Typically, we have seen an upward trend or a fairly flat trend through the years of the National Child Management Programme, which has been running since 2006. Those increases tend to be marginal year on year, sort of between 0.4 and 1.1 percentage points. In this latest data release, it's jumped by an increase of 5.6% for year 6 boys. So that's the increase is about 5 times larger than any increase we've seen previously. And again, I stress that's national data. We don't know exactly from this what the picture in Lincolnshire is. But importantly, we were expecting to see, I think, a deterioration in the prevalence of childhood obesity because of the issues around the COVID pandemic, the change in lifestyles, and the lack of access to schooling for a large proportion of that time. So we're expecting to see it. It didn't surprise us that there was an increase and a sort of an acceleration. I suppose it is concerning that that is such an increase. So for us in Lincolnshire, although we don't know, as I say, what the Lincolnshire data is, that will be seen in the next release of data, which will probably come in November time this year. Lincolnshire has traditionally been slightly worse than average in these results, and there is no reason to think that Lincolnshire would buck the national trend. So we're in a position where we want to understand as best as we can what the national picture is, and then act in Lincolnshire as if we are going to be experiencing the same change in health. It may actually be worse. Sometimes it has been in Lincolnshire, not all the time. The other point I want to make as we talk about what we've seen is that impact on inequalities. Essentially, I often have this conversation with people where I say, do you know that childhood obesity in the UK has been declining over the last 10 years or so in some groups? And that's the caveat there, in some groups, because it has. It's been showing a decrease. Year 6 boys OHID and Public Health England, as was, split the data into 5 chunks. If you look at the top quintile in terms of what we call socioeconomic status, this is broadly those with more resource, they'll have better education, etc. Obesity has been going down markedly and statistically significantly in that group. The issue we have, and this is replicated nationally, is that is dwarfed by the steep increase in the lowest quintile in the socioeconomic groups. So overall, childhood obesity levels are on the up. However, the fact that there is a difference between those socioeconomic quintiles proves that, if you like, it's not inevitable, that there are sorts of reasons culturally, socially, environmentally, why some people and some groups of people, some populations, find it easier to overcome the challenges of the modern world in terms of weight and diet and nutrition than others. And that's something that we've been unpicking through the physical activity discussion. So those inequalities remain. They are increasing and exacerbating nationally. So we expect to see that picture replicated in Lincolnshire as well. So that's essentially the epidemiology. That's what we're here to report on. But I also want to talk very briefly about what we're planning in Lincolnshire. This is a priority for us. It's very clear. The Health and Wellbeing Board, the Joint Health and Wellbeing Strategy, has always made clear that this is a priority for Lincolnshire, and that's really good to see. Obviously, this picture nationally would suggest that should be all the more in the forefront of our mind. So we have sort of seen this coming to an extent. We're very, very well aware that the health of children and young people has been deteriorating in many ways through the COVID pandemic. As a result of that, we started looking at how we can support children and young people and families, importantly, to actually have healthier weight and to be more physically active And there's a clear sort of gap in provision, I think, that we've identified, which Derek alluded to, which we have an integrated lifestyle service. We don't have a specific service for working with children and families. And in fact, the National Institute of Health and Care Excellence, NICE, recommend that areas should have available what's called a Tier 2 weight management service to refer children and families to. So we're looking at introducing that. We've set aside some public health ring-fence grant funds to pilot a programme over 2 years, where we will have a service to refer children to who are identified as obviously overweight, and one of the ways to do that is from the National Child Management Programme. But we want to actually be more ambitious than just having a service, and this is, again, linking back to the conversation we had with Emma, very aware of the impact on not just healthy weight, but on emotional, mental well-being that the pandemic has caused. You know, everybody's been up against it during the pandemic. I know my family was. So what we want to do is try and introduce something which is more ambitious for Lincolnshire, understands what our children and families need, and then does something. And the model that we've chosen is built on our service providers, some previous work that they've done, and we've adapted that. It will fit the NICE criteria in terms of that Tier 2 weight management service. And essentially, we'd like to develop this service where we give children a fun physical activity to engage in. The classic example shared is trampolining. There used to be trampoline parks, which I know my kids loved back in the day. They're getting a bit old now, although I still think they'd like it if they felt enabled to. And that is simply it for the children. You get them active, you get them moving, you're able to have some fun. They make friends. We're not going to preach at them, we're not going to stigmatise them. This is the plan, the service design we'd like to go with. Whilst that's happening, we have qualified, trained, experienced staff who are good at interacting with people to give the families some additional support, coaching, training around diet, nutrition, but also those parenting skills, those macro skills in terms of how to actually, lead the life that most people want to lead. I think, most families would say that the parents and carers are ambitious for their children in terms of having good health and would want to be putting good food on the table. So it's about supporting the families, giving them that coaching and that training in a small group format where hopefully those relationships can build, and some of that, that social capital, that community kind of aspect and that friendship growth can come back in, and the children have some fun, get physically active, get their heart rate up. And importantly, we're keen to try an approach where we have, whilst we do have that referral stream for children who are identified as being overweight, that we also throw this open to an extent, and where we have a professional, say in a school or a GP, who thinks, has identified that this child and family have capacity to benefit from this intervention, even though they might not be over a specific cut-off point, that we can still get them involved if we think it will benefit that family. And that's one of the things that we think is important for our children and families, that we're not doing this as something we're doing to people. It's an offer which will have that sort of multi-component aspect as well, because we're also looking at putting in some initial telephone contact and support. So this is not going to be done just with letters. This is going to be done with people on the phone, inviting people in person. So that is and we've attached some of the details on that. Important to say that that's still in development. So while we set aside some money, we are shaping that with the provider, and we're going through the governance process of getting that finalised. We don't anticipate any issues with that, but we need to wait, I think, at least until the end of the month to get that officially signed off and to finalise the scope and shape of that. But that's very much the ambition behind it, and that's where we're going. I would say that's not the only game in town. Obviously, very keen to remain working with schools. We've got the holiday activities and food programme, which has been very strong through the pandemic and actually has had some fantastic stories associated with it. Very keen to blend with that. And I know we're working closely with Heather's team around the 0 to 19 child and family service as well, which, to be honest, has been the mainstay of provision for this this need in Lincolnshire, as well as family hubs, children's centres, as was, who are also have a strong role to play. So we bring all that together with this additional service, and I think we can start to be ambitious at actually seeing a better change, a better effect for our children in Lincolnshire than maybe in other areas, against that background, that context of the fact that we do think health has been declining. So I'll pause there. Obviously happy to take any questions.
Thank you, Andy. Yes, and if anybody wants to have a good news feel, then just pop along to Washington Primary School, because they are doing some marvellous things there. Hugo.
Thank you. I've read through this, and I have to say it's fantastic. It really is. Having started sort of looking at the whole of the sugar intake and sort of, and the work I've been doing sort of from adults, looking at the whole sort of health, food, nutrition, and I'm in that industry anyway, so, and I sort of got more and more into it, and then I started thinking, well, we perhaps need to be more direct, but we certainly needed to move on from a letter sent to parents that perhaps don't necessarily care too much about the whole situation anyway and tend to perhaps bin the letter. But I think, and so I've sort of itched for looking for what actually we do, and various programs I've watched, it does actually refer to you actually have to be really quite sensitive here. We can't just steamroll in and say you need to do this. The backwards and mental effects are quite catastrophic on it. So to sort of read this is exactly the conclusion and all that I've been doing, that we have to go back to children's and bring the whole agenda through. And I think this makes a cracking start. 79% of childhood obesity is linked to adults. So actually that figure in its own right is an amazing area to address and look at. 4,125 children coming through every year is a startling number, and that means every year adults will be taking that number forward, which has all sorts of implications from health to carers to you name it. To the point, actually, I've spoke to Andy already this morning about it in quite detail, and I've spoken to Sue and to Tricia about it. And that what we're saying is, ideally, is Rob and myself start to team up to champion this, to sort of bring it forward. I think we have got one new Lincolnshire in place. We've got the sports, your active Lincolnshire sort of there as well. You know, it's coming together. We can do innovation, and actually we can deliver something here that none of the rest of the country has got. We can really be a lead and a pioneer. And actually my view is we grab this by the horns and actually really make a difference. And the way the paper's laid out, you know what, I don't want to see 4,125 in 2 years' time. We want to see at least a reduction, and we can see that, and actually we can see the benefits and what will work. My reservation is that actually what we are doing with this is we are having to focus on the people that have no self-motivation in some sense. And actually, we need to motivate them to actually bring about change in their life. And actually, that's quite a skill. And that's why I perhaps actually want to champion it. Because as a councillor, we are there connecting with people in our wards and divisions and of all sorts of walks of life. So actually, I think it brings about a good dynamic to help support this, but certainly I think it is a huge step in the right direction, and with everybody around us and all the support and mechanisms we've got, I think actually we can really make a difference here. Thank you.
Thank you, Councillor Marfleet. Councillor Wright.
Thank you. Yeah, I agree with Hugo's. Great piece of work and to be going on with, but really a question is with regards to quite a lot of obesity being linked to deprivation, and in the past we would have perhaps had a profile of a socio-economic type model of what we would think would be somebody that might be fall into the deprivation. But with the news today that real-time wages falling at the fastest rate for 10 years against inflationary pressures, with more people using food banks and making the choice between cheap food rather than good food, what can we really do about that, and how's it going to help them? Because you can give them as much advice as possible, but if they can't afford to buy what you want them to eat, how are we going to manage it?
Thank you. I'll respond. I mean, fantastic points actually, and I appreciate the support for the intervention. But yeah, I mean, just to be clear, if you were going to try and produce the biggest effect and the biggest change in the population around obesity, if you could, solve some of those macroeconomic issues and some of those inflationary pressures overnight, you would probably produce a bigger effect in the population level in terms of the levelling up agenda and these disparities than we will ever achieve through an intervention. Unfortunately, those aren't levers that we necessarily have we can pull very easily. Nonetheless, we'll continue to try and make the biggest difference we can with the levers and the resource that we've got. And I think this is why previously, and I know Sue, Chairman, has talked very persuasively about the importance of trying to have that whole system approach, in that I often say with childhood obesity, people will say to me, well, nothing really works with childhood obesity because they haven't seen that massive change on the population, and leaving aside the fact that we know it's declining in some groups. Actually, the issue isn't nothing works, the issue is everything works at some level for some people. Because the issues are complex, they're multifaceted, almost anything you can do as an intervention will have a positive benefit for somebody somewhere. So the issue is not how to actually, the issue becomes one of effectively cost effectiveness, bang for your buck. How do you scale something at a population level that will have the most effect in the population? And an important point here is that we don't know what changes are going to be happening in the macroeconomic system over the next couple of years. Those pressures could increase. The changes that we've seen through COVID in people's lifestyles could embed rather than amend. We could be seeing a worsening of the figures over the subsequent years, even if this service and other services that we're doing are effective and are working, because of course we don't know what the baseline we're working against is going to be. But that is the joy actually of working in public health and in trying to make the public sector have an effect. Actually, that just forms the context for what we do, and we still need to do the due diligence to use the resources that we've got to make the biggest impact. And in terms of our understanding of the evidence and our review, a service like this could have a significant impact and could use our resources to the best, but it would still be dwarfed by the effect that could be achieved if that true whole system approach, including the national macroeconomic levers, were able to align. So I completely agree with your points. That forms the context, the landscape, if you like, that we've got to navigate. Even if it's a declining picture nationally and locally, we still want to try and make the best impact that we can.
Thanks, Andy, for the paper. So just a couple of thoughts. Firstly, a bit like the Let's Move presentation, my mind immediately goes back to this new statutory ICS, our 4 core purposes: reducing health inequalities, improving health outcomes, adding social value. So this plays right in full square into supporting that. Clearly, the statistics you quote, regardless of whether they're precisely accurate, are hugely worrying, aren't they? Genuinely hugely worrying for the health of young people in our county. I think the statements about how can we help you and you help us with this, how can make sure it's connected in, social prescribing, GP services, third sector activity, all of those sorts of things, district council work, I think is really, really important. But I've got a question that I can't quite see the answer to, but I'm sure you'll satisfy me with it. The first is, how will we know that what you're asking us to sign up will work? So something about the evidence base, just to be comfortable that there is an evidence base behind this that it'll work, rather than it's just a sort of hopeful shot. I'm sure it's not. And the other is, are we kind of going to hang our hats on any particular outcomes from all of this? A reduction in the increase of, an increase in the reduction, is it, of healthy weight? You know what I mean, or some positive flags that we would be looking to shoot for. You wouldn't expect me to ask any of the question, Derek, so thank you.
I've just said to her, can I answer this? Just because I'm going to bat that one back in terms of saying, as Andy said, the evidence suggests, and we've got it really strongly, it's in all the NICE guidelines, that pretty well anything you can do in this area is going to have a benefit for some. It's about where to put it to have the maximal impact. And the reason I'm going to bat it back is there is a huge amount of stuff we do in the NHS that has no evidence base whatsoever and probably makes things worse. So we need to look at a system here, I think. So when we look at anything about an evidence base, and it's one of those, because public health people tend to stand up and go, rah, evidence base. It's quite appropriate everybody goes, show us the evidence, but we've got it, and I can provide assurance and we can give you chapter and verse. But we need to recognise, and I know you get this, and everybody in this room gets this, as we move into a proper integrated system, health and social care system, we've got to start to look at where are we spending money, full stop, that could be spent better elsewhere. And I guarantee, and we have the evidence base, just look at the Marmot reports, look at any of the international evidence, that stopping doing some of the stuff in the NHS that isn't effective or is marginally effective and putting it into these sort of interventions, even if it is more to do with people who are waiting for a hospital admission, maybe for an inpatient and getting a GA, a bit of weight loss, stopping smoking has a massively more beneficial effect on their health outcomes for that surgery than probably 9 out of 10 things we try to do to them as clinicians. So it's a bit of a, I'll throw it back. The challenge is, I'll show you mine if you show me yours. And if you like, I'll start to give you some answers, some areas that you may want to look at.
Okay, thank you. Heather.
Thank you. Mine was really drawn attention to the district variation. And obviously all of the data shows that Boston for Lincolnshire is an area of increasing concern. How are we going to ensure that the scope of the programme really shines a light on Boston and understands the unique communities there, and how we really get a programme like this to land well there?
Thanks, Heather. Yeah, really good points, actually. And we are seeing many of the same health inequalities cropping up in the same areas, and we're feeding that into the health inequality work programme. So actually this becomes a bigger question than just for this issue and for this programme. But nonetheless, you're absolutely right. And the approach we're taking is one we broadly call proportionate universalism, which is where we're looking to put the offer out there everywhere it's needed, but resolutely targeting the resource, going back to that financial cost effectiveness argument, on the areas where it's needed the most. So we very simply, and it'll go, when we go through to the provider and we do the recruitment, we will put more workers, more sessions on in the areas that need it the most, and that will definitely include Boston.
It's probably that really good example of triangulating those three questions, really. It will be building a model that works in that community at that time, and that's where having probably a more flexible arrangement with the provider, because they'll know better with their local communities, co-produce it along with Active Links and other partners about what's going to work where, and it will be different. We're a massive county with huge differences, so we've got to tie that in and work with our district colleagues as well on that.
Thank you, Derek. And final question to Emma.
Thank you. It's a point actually really closely aligned with that in terms of the wraparound service. So similarly to the point I think Councillor Wright made around the adult who might go swimming for a few weeks and then that free support stops, we need to make sure that we're really well connected so that when the people come out of the funded programme or the service, there is something else that they can go on to that's relevant and sustainable. So really keen to make sure that we join those dots with you on that.
Okay, thank you for that. Final two items are information items only. So we've got an action log of the previous decisions. I'm assuming that no one has any points to raise on those. And finally, the forward plan. And as always, if you have any items that you want to put on the forward plan, then if you direct them towards Alison, then she'll make sure that we find a slot for them. Thank you, everyone, for your attendance.
Excellent. Very good.